Good evening, all the aspirants present here. Today's the topic is nutrition, and the speaker that we have here is Dr. Nilanchal Chakraborty, sir. He is a consultant critical care at Apollo Multi Speciality Hospital, Kolkata. Aspirants, this is going to be a very interactive session. It will be a question and answer session. Please do answer in the chat box, or also you can unmute yourself. Thank you.
Yeah, so we discussed last time about nutrition in critically ill. Sorry if my slides are not moving. Okay, we talked about what is medical nutrition therapy. The isocaloric diet is 1 meal in 1 calorie. Hypocaloric is when we are giving 70% of the defined target. Trophic feeding is very minimal just to maintain the intestinal villi and mucosal function. And when we are giving a feeding calorie requirement more than 110% of the target, we call it overfeeding. We should assess all critically ill patients in ICU who needs nutrition therapy and calculate the energy requirement of the patient. We have a score called mostly used Nutric score or NRS 2002 for assessing who are at risk of poor nutritional therapy because the Nutric score if correlates with the mortality. So when the patient is having a Nutric score of more than 5, they are at high risk of ICU mortality. So to consider in the Nutric score, you need to check the comorbidity of the patient before the admission, the weight, the dietary history before the hospitalization, and of course the body mass index. Then we can calculate the ideal body weight based on the height of the patient, what are the different medications he was getting, and then check for any risk of malnutrition, check for any muscle atrophy, subcutaneous edema, loss of subcutaneous fat. Then in the early phase, we usually target a lower calorie, fast 24 to 72 hours, I'll say, reaching up to 70% of the target. Then when he's tolerating that and all the electrolytes are optimal, then only after 72 hours to 5 days, within 7 days, we try to achieve 100% of the energy requirement. The root of the nutrition and oral diet, if the patient is taking orally, if the patient is not taking adequately, we can insert a nasogastric tube or nasojejunal tube for feeding. And if the patient is not tolerating total enteral nutrition, we can combine with parenteral nutrition. But the comparison between the enteral parenteral group has no difference in terms of mortality of ICU patients. But of course, giving a parenteral therapy either through a dedicated line incurs risk of that line itself. And of course, parenteral nutrition is not physiological, doesn't enter the enteric system, so doesn't help in the biliary system or enteric mucosa. It has own risk of the line-related infections, pneumothorax, and bloodstream infections. So risk of giving a parenteral nutrition, of course, is higher. And if you don't give enteral nutrition, chances of bowel malfunction is always there. But we have to consider when there is vomiting, diarrhea, bowel ischemia, and all for considering parenteral nutrition. So, any questions regarding this part? So the enteral diets can be different types. The polymeric, the most common one we eat orally, has good content of fibers where we need to digest them, the protein to peptides, and polysaccharides to oligosaccharides, and long chain triglycerides to medium chain. It comes semi-elemental. When there is some gut abnormality of digesting them, then we need to give more formula feeds containing free amino acids, simple glucose, and medium chain triglycerides, like elemental diet. But these elemental and semi-elemental feed doesn't contain any fiber, so not for good stool volume and content of water. So the semi-elemental diet is favored when there is short bowel syndrome to improve nutrient absorption or some conditions like pancreatitis. Advantages of internutrition we detailed last time. Of course, it's much more physiological. No central venous related related issues and fewer infectious complications. And of course, feeding is less costly than parenteral nutrition. And but is some contraindication when the patient cannot take orally, or some concerns about bowel ischemia or abdominal compartment syndrome with intra-abdominal pressure is high. We have to consider. Am I audible? Hello? Hello?
Yes, sir, you are
Yes,
audible.
sir, now you are audible.
Okay. So, um, the contraindications of enteral nutrition, some of them are no longer a contraindication, like use of neuromuscular blockage, therapeutic hypothermia, prone positioning, traumatic brain injury, stroke, etc. In this condition, if the patient tolerates heat, we can give heat. Okay. Okay. So now some studies have shown that checking the gastric residual volume doesn't increase the risk of ventilator associated pneumonia. So maybe twice daily. We don't know actually how frequently we need to check. But of course, in practical sense, when it is not more than 50% of the volume being given, we usually continue to feed. Some centers take a gastric residual volume of more than 500 as a cutoff for slowing the feed. Some centers take 200, but there is no difference in outcome. So checking gastric residual volume to stop, lower down, or giving feed doesn't make much difference. Continuous versus intermittent feeds also similarly, if you're giving the feed as a bolus in 500 ml, then giving it may increase the chances of bacterial contamination. If you're giving a bag containing 1 liter, usually you give 1 liter a day. 500 ml bottle comes in when you're giving through continuous infusion. The enteral nutrition has to be titrated, as I said, over 7 days. You start low and go slow to reach up to the maximum level in 5 to 7 days. Gastric versus post-pyloric feeding. When the gastric residual volume is too high, some centers insert a nasojejunal tube or fracus tube across the pylorus of the stomach so that the gastric paresis can be overcome. Otherwise, we can use different prokinetic agents for giving gastric feed. Prokaryotic agents are various, like erythromycin and metoclopramide can be used in different dosing. And commonly we give usually a nasogastric tube feeding. And if it is for a shorter period, not more than 4 weeks, more than 4 weeks, then usually we go for a percutaneous gastrostomy tube. Cochrane data analysis have shown that post-pyloric feeding in critically ill patients, of course, causes less gastric residual volume and less chances of aspiration pneumonia. Other than that, post-pyloric feeding has no other extra benefit. So the complication because of the insertion and A frequent removal of the fracus tube can cause more complications. So nasogastric tube is much more safe and can be used in critically ill patients. So when you ask for a post-palliative feeding, you have to call a gastro team, fluoroscopy, radiology, so that they can insert in certain hours. So starting optimal nutrition always get delayed. So in that sense also, gastric feeding favors rather than post-palliative feeding. If the patient is getting nutrition for more than 4 weeks, we usually call the gastro team for endoscopic percutaneous gastrostomy tube, but it has its own complications and contraindications. Patient having ascites, portal hypertension, gastroparesis, local abdominal infections, and previous laparotomy scar, and coagulopathic patients. This is a more invasive thing, cannot be inserted. So if the patient is not getting proper enteral nutrition, parenteral nutrition has to be considered, like malnourished patients, and to avoid overfeeding. So energy needs, as I said, has to be calculated based on the ideal body weight. Usually, we assess case by case, titrate all the electrolytes, including phosphate, before going up on the isocaloric diet. Carbohydrate, protein, and fat have to be optimized. Usually, we give around 1 to 1.5 gram per kg per protein, and excluding the protein, usually the carbohydrates are 5 milligram per kg per minute, and lipids, as it's more caloric, it has to be titrated as per the caloric need. Parental nutrition has, as I already said, has some limitations due to the insertion line, due to the central line. And the absolute concentration is when the patient can take orally, you should not give parental nutrition. So when you don't have a central line, electrolytes are still at DSRA, and patients having terminal disease, parental nutrition should not be used. Usually it can be a combination of amino acid glucose, or maybe lipids also can be combined with it. Okay. Monitoring of the complications with parenteral nutrition is basically monitoring the electrolytes, and there is sorry. Yeah. Whether you give enteral nutrition or parenteral nutrition, having a bad sugar control always impacts the mortality in ICU. So if it is more than 180, then mortality increases. So parenteral nutrition indirectly increases mortality. Other than that, if the patient is having diarrhea due to recent antibiotics and all, the feed absorption is not adequate, then only you can use this parenteral nutrition. But you have to rule out any other infections like C. diff, which can be treated. If the patient is having transaminitis and liver abnormalities, then also parenteral nutrition is not that ideal. Hyperlipidemia, triglyceridemia are known complications of parenteral nutrition because the gallbladder remains suboptimally functioning while using the total parenteral nutrition. It is more commonly used when the patient is having pancreatitis and feed absorption across the duodenum is not that adequate, or else if the patient is getting hypertriglyceridemia due to the TPN, then also it can incur pancreatitis. So both way, it's a double-edged sword in pancreatitis. It can cause pancreatitis, but sometimes it is more commonly used in diseases like abdominal conditions like pancreatitis. If the electrolytes are not optimal and the pre-feeding electrolyte status isn't optimal, patient may have increased insulin surge causing potassium and phosphate and magnesium shift intracellularly, causing refeeding syndrome. Risk factors is low BMI, and if the patient is already on drugs like insulin, chemotherapy, antacids, and diuretics. So, the complications management is very simple. You anticipate refeeding syndrome, you correct the electrolytes before you go on giving TPN in the full dose, and then you optimize the vitamin, phosphate, potassium, and magnesium. Pathophysiology is because of the certain nutrition surge with glucose surge, insulin increases in the body that causes intracellular shift of all those intracellular ions like potassium, magnesium, and phosphate that ultimately cause derangement of the ATPase dependent pumps, causing different muscular and autonomic failure. So, other complication is hypertriglyceridemia. We consider when the triglyceride level is more than 540 milligram per deciliter in critically ill patients. It can happen when the patient is on propofol or TPN. In that case, also you have to titrate your parenteral nutrition dose. Immunonutrition is always discussed and very controversial in critical care area. It is basically when you think of nutrition other than carbohydrate, lipid, and fat, the omega-3 fatty acids is only targeted in special patients. It is indicated in usually given not to given in bolus doses. The omega-3 fatty acids and in parenteral lipid emulsions with fish oil dose of zero point 0.1 to zero point 0.2 gram per kg per day can be used with parenteral nutrition who requires omega-3 fatty acids. Should not be used as a monotherapy. Daily supplements has to be given along with other trace elements and vitamins. Glutamine is the other solution, which is usually is I'll say suboptimally raised in critically ill patients, and some special population may get benefit, like the burn patients. More than 20% of the body surface area burn and should be continued for around 2 weeks. In trauma patients, recommended dose is around 0.2 to 0.3 gram per kg per day, around first 5 days. And when the wound healing is a concern, you can stretch it to 2 weeks. Unstable ICU patients who are in shock and renal failure, liver failure, glutamine should not be used. So omega-3 fatty acid, acceptable. Avoid giving high enteral dose boluses. Glutamine is beneficial in burn and trauma, contraindicated on liver and renal failure. Okay, this summarized. So any questions regarding this, I can answer shortly. If no more questions, I can stop it. Okay, thank you.
Any aspirants, any question you may ask now? Sir, I believe they have no questions. Thank for this session. Thank you, sir. We will be ending the meeting here.